Welcome and thank you for joining us today. My name is Nate Wade and I co-lead the ASU College of Health Solutions COVID Commons Initiative with Mara Aspinall. Mara is a professor of practice at ASU's College of Health Solutions and a diagnostics industry expert who helped found our master's degree in biomedical diagnostics. Mara and I would first like to recognize and thank the Rockefeller Foundation for their generous support of our COVID Commons Initiative. We would also like to thank our partners at the World Economic Forum who have been instrumental in helping us with all aspects of the Workplace Commons. Before introducing our panelists, a few housekeeping items. First, this session is being recorded and it will be posted on our website, asucovidcommons.com. Next, we will have discussion and Q&A sessions throughout the webinar. Please submit your questions using the Q&A feature. We value your feedback and plan to send a brief survey asking for your input about today's webinar and ideas for future event topics. Finally, we encourage you to get involved in our COVID Commons community by visiting asucovidcommons.com. Now that housekeeping is behind us, I'll turn it over to Mara. Over to you, Mara.
Hello, everyone. Thank you, Nate, and it is great to be here. Welcome to today's webinar, COVID Diagnostic Commons, Surviving What We Hope to Be the Last Lap and Planning for What's Next. To say that we're in a new phase of the pandemic is putting it lightly. It feels like the world is a new place. But while we in the US are working slowly and inching towards new record lows, places like India, Brazil, Vietnam are still working through record highs and their own surges with very spotty vaccination programs. So the question is, how do we navigate through this hazy phase of safe and unsafe? Will we ever reach herd immunity? Can diagnostics and testing offer certainty? What are we going to do with all the data we've collected? And how will our society change from here going forward? So the fundamental question now is, how can we firmly and reliably take back control from this virus? To discuss this, we have 6 impressive and incredibly strong leaders from different parts of the ecosystem who have and continue to play critical roles in fighting the pandemic. So as is our custom, I will introduce our panelists and then we'll have time for dialogue and questions. I'm very pleased to say that we have a number of panelists today, 6, and they are all part of our ASU Rockefeller Testing Expert Program. So they have different areas of expertise, which will make the conversation all the richer. So I'm going to start with Malia Atkins. Malia has worked in a range of economic and healthcare policy issues with a current focus, clearly, on the COVID-19 pandemic. Prior to her work as a policy consultant, Malia worked on Senator Elizabeth Warren's 2020 presidential campaign. She was a manager at Avalier Health, a legislative aide to Senator Warren, and a community organizer on a number of national and local campaigns. She holds a BA in public policy at Brown and an MBA at University of California, Berkeley. So Malia, can you say hello and share a little bit about your involvement with COVID-19, specifically in related to new policy development?
Yeah, absolutely. And thank you, Samara, and thanks everyone for the opportunity to be with this amazing group of folks today. So as Mara said, my background is as a community organizer, and I worked in health policy for many years. So for me, from the really beginning of the pandemic, what struck me was just the kind of pervasive inequity of all parts of the disease and our response. And it wasn't just the short-term inequities of who the disease was impacting, but it was also the long-term inequities that were forming. And in particular, I was really concerned about children. And well, I think no parent of a school-aged kid has had an easy last 15 months. Our parents with means have just been much more able to stem learning loss than those without. And they've created basement classrooms and hired tutors. Whereas low-income parents who send their kids to public schools, that many of which have been closed for the vast majority of the last 15 months, have really had many fewer opportunities. And I am just very worried and still am that we will emerge from this pandemic with just a much wider achievement gap than we entered. And so kind of thinking about solutions, one of the things I became very interested in was diagnostic testing and sort of how it might be used to bridge that gap. And some of the first entities that had access to regular diagnostic testing in this pandemic that I encountered beyond residential nursing facilities were the NBA. And there was a group of kind of elite research universities in Massachusetts that were doing some great work with regular screening testing. And all of these entities did amazing work piloting protocols and sharing their learnings. But in my opinion, policymakers were just kind of too slow to think about how to expand access to that type of testing to those that needed it the most and would benefit the most from it. And so that was sort of the premise that I, along with some amazing partners, including Mara, founded a group called COVID-19 Response Advisors, which is committed to expanding access to COVID-19 testing for underserved populations. And we were really focused on kind of three ways to do that. First was working with labs to kind of help them develop the types of tests that would best serve those communities. The second was proving out that testing programs work, and they can and they do work, especially in K-12 schools and childcare settings. And then the third was sharing those learnings with policymakers in an attempt to kind of influence what was being funded and what was being supported. And that's an area where we've had a lot of success, in particular supporting the federal government's school COVID-19 testing programs. And that has been a great collaboration with the Rockefeller Foundation's K-12 National Testing Action Program. So.
Thank you, Malia. And I'm sure we're going to come back to that issue of school testing and what is appropriate to remain open. And but I appreciate you mentioning the heroic efforts of teachers and parents to keep kids learning. It's not perfect, but at least it happened. So our next speaker is Dr. William Morris. I have to say, has Mayo Clinic in his blood. He graduated from Mayo Medical School. He trained at Mayo. He began a career in pathology at Mayo, is now the chair of laboratory medicine and pathology at Mayo. During his career, he's been involved with an introduction of a myriad new assays for the diagnosis of leukemia, lymphomas, in particular, plasma cell proliferation disorders is his focus. He has published over 100 letters, manuscripts, and book chapters, and given speeches specifically about diagnostics and the role of the clinical lab worldwide. So with that, Bill, welcome. And let me ask you, how has your lab changed specifically in response to COVID? And how did you balance the needs of the clinical care on a day-to-day basis? Mayo certainly didn't close, with your needs to do COVID testing.
Well, first of all, thanks for the opportunity to be here, Mara, and to join such a great group of speakers. It's a great opportunity. It changed. First of all, as you know, coming in, one of the things I've been passionate about through my career is just people in healthcare and outside of healthcare really recognizing the importance and the value that diagnostics bring to the table and taking care of patients and take care of individuals in public health setting as well. So coming in, the focus prior to the pandemic, the focus at places like Mayo Clinic and tertiary care was not really on infectious disease, right? It was a lot on cancer and personalized medicine, individualized medicine. That was really the coin of the realm. And so you had to pivot to all of a sudden doing very high volume, high throughput testing and trying to engage. Of course, we have a hybrid here where we're an academic department that also serves as a national reference lab. So for us in particular, it meant refocusing, restaffing, retraining people to work in a 24/7 high throughput laboratory. As a clinical lab, it meant strengthening bonds between ourselves and the diagnostic manufacturers like Roche, Thermo Fisher, PerkinElmer, others. So those things, it really just kind of led to this disproportionate kind of shift in focus to try and get a singular activity in the lab and throwing a lot of things that we normally do kind of out the window. So as a, for instance, I think at the peak, we had 9 different molecular platforms running just to make sure, because we had to, play hopscotch between different platforms that had reagent availability and plastics availability and all those things. So it really changed. The other thing that changed for us as collectively was just a lot more of a call for people like myself to be part of the public dialogue about how to use diagnostics, really coming off of Malia's comments about how do we do this? How do we do this right? What are the gaps in the infrastructure that have been exposed by the pandemic? So a lot of working in Mayo and outside of Mayo with you and with others. I also was involved with the World Economic Forum and the Access to COVID Tool Accelerator, a diagnostic industry advisory group. So trying to advise industry on what was needed. So just really a maelstrom of activity. And for the staff in the lab, it was really quite disorienting. You had to, it was as they were dealing with kids at home and all those things, asking them to work off shifts. We had to go through furloughs as a hospital, then bring people back to the labs, and then the logistics. We do almost all of our testing in Rochester, although for COVID, we did a lot in Florida. At our peak, we were getting in about 100,000 specimens a day just into Rochester to try and process and get through. So a lot, it was a lot.
It sounds like that. It sounds like maelstrom is a word that is not often used, but clearly relevant to what you were doing on a day-to-day basis for so many months. So again, we will come back to many of those issues. Our next speaker is Dr. Nancy Gallagher. And Nancy is an internist by training, but she's had an extensive societal impact as a physician, but also as a business and policy leader. She currently leads the Rapid Acceleration of Diagnostics, known to most of us as RADx, and she leads the RADx Tech Large Scale Deployment Core, and it supports NIH for COVID testing nationally. These are the folks that have made such a big difference in bringing new technologies to the market. Previously, she spent over 6 years at CVS Health as Senior Vice President and Chief Medical Officer of Minute Clinic, overseeing the quality of care, point of care testing, and growth expansion for their 1,000+ clinics, seeing 6 million patients annually. She spent 21 years at Mass General Hospital as a Harvard faculty primary care provider and ultimately the Senior VP for Practice Improvement. We're going to hear from Dr. Friedman later about the Harvard system as well. Nancy, welcome. And maybe you could talk about what you're doing now and the RADx impact on COVID tests and their market availability.
Thanks, Mara, and thank you all for having me. What a great opportunity. So RADx Tech has been an amazing opportunity. A little over a year ago, the Congress gave the NIBIB over $750 million to help select the best of the best promising companies to pick those companies that had the potential of dramatically impacting COVID testing across the country. And the goal was to find innovative companies that were poised to do diagnostic testing, to advance point of care testing, PCR testing, antigen testing, OTC testing. Our charge was get as many tests, different types of tests out on the market as quickly as possible. And we brought together academicians, business executives, different government agencies. We have about 500 people who previously never really worked together, working in concert to make this happen. We now have 33 companies that have been supported by the NIH, and we have roughly about 30% of the tests on the market are currently, because of the RADx program. We know that we took about a 4-year business cycle and cut it down to about 12 months. It's just been extraordinary, something to learn for the future. But the other thing along the way that we learned was that the country had historically, and I think Bill had mentioned this, really thought of academic organizations as the fulcrum for testing. And here we're starting to think about, let's get testing in schools and businesses and out and in tents and out from tents and at home. And our country just doesn't have the infrastructure, the knowledge, the logistics to support diagnostic testing outside of healthcare communities. So we've really been trying to focus on how do we make it easier to deploy testing. And this is not only for COVID, but hopefully for something for the future. So it's just been quite an experience.
Thank you, Nancy. And I appreciate, one is that amidst so many people working long hours, nights and weekends, having worked with you over these last 9 months, I know that the same is true of government. So thank you for all of your work, your team's work in making this happen. And also acknowledging the fact that it's not going to stop with COVID. We have to use these diagnostic technologies for other diseases going forward. So now we're going to shift a tiny bit to a speaker, Dr. Manny Valenzuela. Manny, it comes to us from the educational perspective and clearly on the cutting edge, as he is the superintendent of the school district in Suarita, Arizona. It's a rapidly growing K-12 district just south of Tucson, Arizona, and it's one of the very first in the country to begin COVID testing with the ICAT program, the Increased Community Access to Testing program. Manny is well known as an innovator amongst his peers, an innovator not just in Arizona, but nationwide in bringing creativity to his students, to his teachers, and to the parents that they serve in the community. He is well loved and well respected. He is one of the first 27 superintendents in the whole country to graduate from the National Superintendent Certification Program, living by the fact that you continue to learn. And he was honored recently as the All Arizona Superintendent of the Year for the larger district. Furthermore, he received national honors from the University Council for Education Administration with their Excellence in Leadership Award. So with that, Manny, you are clearly an educator first, a business person second, because you have to be. You implemented a testing program in your district. How did it go?
Actually, I think we all need a message of hope, more than ever, perhaps. And I was really affirmed and encouraged by the power of possibilities that are presented by a common foe, in this case, the virus. When Mara called and said, as a country, we're working on developing these testing protocol and programs, and we'd like you to be part of the pilot. And we had like 2 weeks to get the whole thing together, and with all of the regulations and privacy issues and logistics, it was challenging. But I got to tell you that the power of possibilities, when you have public, private, government, non-government, local people, local health departments, national, working together, we were able to implement a testing protocol that offered testing to all staff, all students on a weekly basis. It was logistically, once we got the kinks out, which you would expect with any kind of a program, a big program, let alone a new one, it was tremendously successful. And I think it does speak to the power of collaboration. And, the way I see it, what I've learned, again, as an educator who was thrust into this whole world of the pandemic, like all of humanity, is we've got to use every tool in our belt to tackle this thing. And testing is a part of that. Logistically, things went very well. I was grateful for the opportunity. I think it plays a vital role. I'll tell you though, the place where my bubble was burst was in the participation rates. I was kind of surprised that we had we have about 5,800 students right now. We got a dip like most districts across the country. We only had about 400 students. So it was like between 5 and 10% participation. And it was a little disheartening because here we worked really hard to provide this resource to assure people that schools are safe, to minimize the risk of transmission. And we had such small participation. But there's silver lining because we did learn stuff. And the biggest thing I learned is that a lot of this is about trust. This is all new. There's a lot of question. There's a lot of perception and misperception, information and misinformation out there. And it's our job to communicate with as much clarity as we can. And I think we did a good job, but I think there's even more opportunities. I think that's where I guess the next steps lie, is in helping to educate people about things like simple. Some of them I grappled with myself, like, for example, the 3-foot radius, which allowed us to come back, compared with the 6-foot radius that will quarantine people home. So I understand it in my own educational world, but at the same time, I understand how parents feel that presents almost like a risk, like I participate, but if I'm positive, then my kid might not get to play in basketball that week. And why do you tell me I can be 3 feet, but then 6 feet will get him sent home? So, and I know we're working through some of those things. Some of them, frankly, are just misunderstandings about the nature of the tests, the fact that we don't put the Q-tip all the way up to the top of their nose anymore, that doesn't happen. And those, or just those kind of things that people are fearful about, what we're doing with data, privacy, all that stuff. So I think the silver lining for us is we learned a lot logistically. That's really encouraging that we can do this and we can do it well. And this can be a part of our tool chest to move through and keep schools safe and open, but that our opportunities for refinement, to me, are largely in the area of community collaboration, outreach, and really building trust with our communities. And that's challenging, but I think that's where we got to focus.
Manny, thank you for that. And thank you for that realistic look that it went well, but certainly 10% participation is not where we need to be. I will emphasize that is not unusual. Most of the rates were a little bit higher than that, but in many schools, as Malia knows, the participation rates were low. In addition, many schools that were technically open only had 40 or 50% of the kids there. So we need to work on that. To that end, I'm going to go off script for just a minute. You're going to see sometime soon in the next week, Rockefeller will be releasing a study with the RAND Institute of thousands of parents across the US and how they perceive testing, how they perceive sending their kids to school, and what are the challenges to do that. So if you're interested in getting that, put your name in our participants, put your name in the Q&A, or send an email afterwards. We'll make sure you get that study. But I will say I've seen a preview of the study, and Manny, your comment about the back of the nose, the NPS swab, the nasopharyngeal, is so correct. Many parents who were only tested early on assumed that was the test that their kids were going to get in school, and they said, heck no, I'm not going to allow that to happen. So moving on, we'll go back to kids. I am very pleased to introduce our next speaker, Dr. Stephen Friedman. Dr. Friedman is the director of the Pancreas Center at Beth Israel Deaconess Medical Center in Boston. He's the chief of the Division of Translational Research and a professor of medicine at Harvard Medical School. Steve is internationally recognized leader in all of these areas and runs an extensive research program and training program that encompasses both basic science discovery as well as clinical trials in so many areas. He has played a leadership role in virtually every association in clinical and translational research nationally and internationally. Steve helped establish the Cystic Fibrosis Foundation program to train pediatric and adult gastroenterologists in the GI aspect of CF, many of which are not well understood and not well recognized. All of that is impressive, and he is impressive, but I would say he is first and foremost known for his ability to connect with people, with patients, and diagnose even the most challenging of situations. So Steve, it is wonderful to have you here. And you can really talk in a very different way about being on the front lines of the COVID challenge during the peak in Boston. What was that like? I mean, such a naive question, but how have things changed and what are things like in Boston in the hospitals today?
Mara, thanks very much for having me here. You know, I'm so impressed hearing from these other panelists, and I think probably one of the themes that we're all bringing up is plasticity. I mean, these were kind of unprecedented times, which we didn't know how to address. And I remember when this hit in March of 2020, full tilt in this country, and especially in Boston area. Two things I like to bring up as a result of that. And first is we all learned how to pivot rapidly. We had two challenges in front of us, and one was how do we protect ourselves? I mean, providers were dying besides patients. So how did we take care of ourselves? But we clearly had a mission of taking care of our patients, and how are we going to do that as well? If you told me 2 years ago I'd be coming home from work, taking off all my clothes in the garage, putting them in bleach, and I'd have to scrub down before I could even get near my wife, I would have told you you're crazy. But that's what life became. We learned about masking up and double masking and trying everything possible. So I think the first was the pivoting aspect, lots of meetings, and the theme that you heard is we all from all different disciplines pulled together and figured out how do we take care of our patients, because that was still number one on our priority. And I think the first 3 or 4 months were incredibly tough. We shut down everything elective that we could. Most of us physicians, as a result, were taking hits in our salary, but that was just, unfortunately, a byproduct of all this. But we said, okay, how do we take care of our sickest patients? And I think we did an awfully good job. We learned a lot in that first surge that informed us by the time the second surge was hitting, and especially by the winter of 2020 here. And we got a lot better at how to manage patients and how to still protect ourselves. So I think this pivoting rapidly, which is probably a theme that we're all talking about here, was the first part. And I think we're doing relatively well currently in Boston as a result of that, but we're still not out of the woods, and we're all nervous of, could we have another third surge here with this Delta variant? I mean, we just don't know. People have to protect themselves. And a cautionary note is that everyone, like walking around Boston without masks now saying, yeah, this is great, we're all set. But, just if you look last night, 5 people died overnight of COVID. So, yeah, it's a lot lower. We're not out of the woods, and, we don't want another surge. I think the second aspect from pivoting rapidly is we learned how to take advantage of virtual technology platforms. Telehealth, which most of us didn't even know what that was, that became our mainstream. And we've learned how to continue to use that for certain patients and for follow-up. And it's allowed, I think, a lot easier access for patients to get the care they need. I think the second aspect of the virtual platforms is education. We have a record number of people at 7 a.m., like this morning for GI Medical Surgical Conference, because you can still be in your pajamas and everyone can hop on. And I think this is a way we're educating a much broader community out there that we never thought of before the pandemic. I think that's a plus side, if there's plus sides of this pandemic. The second aspect is, many of us, and we had this before COVID, but we've all expanded on having multidisciplinary conferences where if one of you here is ill, we can be flashing up all your images electronically. We can have our surgeons, our oncologists, our pathologists, everyone is there virtually that can weigh in. And so one patient now benefits from having 60 specialists once a week weighing in on their cases. And so now we're continuing to take advantage of these virtual platforms.
I love that. And the key word that you've said is pivot. Pivot for better patient care, pivot to keep the doctors themselves healthy and still motivated, and use it for education going forward. So thank you and your colleagues for all that you've done. So our last speaker before we open it up to Q&A is Alex Alonso. Alex, it represents a part of the ecosystem that we at ASU have talked about have not played a big role, which are employers. Until recently, many employers were actually relatively silent amidst COVID-19. People who could go home and work from home did, and those on the front line obviously couldn't. But we wanted to add somebody in our team that could talk about employers and the human resource perspective. So Alex is from the Society of Human Resource Management. He is also called SHRM. He is the Chief Knowledge Officer. He leads the operations for SHRM Certified Professional and Senior Professional certification. He heads research functions and their Knowledge Advisor service. Throughout his career, he has published works in peer-reviewed journals, authored several chapters on community change, and all about initiatives in workplace readiness. Clearly something we need today and going forward. He serves as a columnist analyzing major workforce trends in the Industrial Psychologist and HR magazine. So Alex, can you tell us about the role that SHRM and in particular human resource managers are playing in helping employers and employees manage the pandemic and manage getting back to work, which could be just as psychologically fraught as leaving work in person?
Well, so thank you all for having me here today. And I'm sort of an odd duck in that my doctorate is in industrial psychology, which is actually focused primarily more heavily on the workplace and specifically what organizational behavior looks like. And as I listen to all of you, it's funny how we all described different elements that were affecting communities, but focusing and actually transferable to the ecosystem that we all live in more than anything else, which is our workplace. And so, Steve, as I heard you refer to what it was that we were doing from a plasticity perspective, it reminded me of the early days of the pandemic, where not only were we concerned about making sure that people could, in fact, be safe and stay healthy, what we were also focused on was how they would still maintain their livelihood. And that's a troubling question that, or a debate that was particularly difficult. You don't want people to have to choose between life and livelihood. And so I remember back to what our work was back in the early days. SHRM as a whole represents more than 1.6 million HR professionals in the US alone. We represent over 2.5 million workers, not workers, organizations or employers across the globe in more than 165 countries. And it took me back to our work with the WHO, the CDC, and the International Organization of Employers, where we created education really around what Manny was describing, which is helping dispel miseducation or misinformation around the pandemic. And then also following two specific tracks. First and foremost, it was really following the individuals who needed to understand what testing meant, how they went about testing, and what they could do to make it available for their workforce, if anything at all. And then the second piece was really focusing on how you create a safe workplace. And the reason I say that is for about 60% of the population, that workplace really was working from home. But there was that other 41% of the population that could never go home. Not just the frontline workers, but also the essential workers, the ones who never could leave their essential operations, which really were disproportionately affected as you looked at this. And SHRM as a whole really focused on doing one thing. First and foremost was educating the HR professionals around what was true and what was not true, and working specifically with the CDC to do that. I can tell you that just for that first 2 weeks alone, we had 3 different webcasts with more than 100,000 participants each. The second thing was standing up an information center primarily designed to support all these organizations that we dealt with. We fielded over 600,000 different inquiries in the first 10 days. 600,000 inquiries, just people seeking information. And then the last piece was really doing something that provided individuals with a clear piece of guidance around what they could do to support and offer additional incentives to help their workforces engage in a safe pattern of behavior, right? We know from the first phase of the pandemic that human behavior was as big a contributor as the biological factors. And we know, for instance, that people not being socially distant was a particularly difficult component. Manny, you described how now we're in the stage of trying to understand how 3 versus 6 feet works and where it is that we should do. Protocols for social distancing were a key component to what we were looking at. And it was our job really to help inform organizations as well as their people managers and their human resource professionals to do that. It was not an easy job, as we've all described. None of this was easy. But the second piece of that was also then helping organizations institute the kind of policies as well as find the kind of resources they needed to make this possible, including testing. That was something that was particularly difficult, and I will share with you is still a struggle for HR professionals today. While we represent those 1.6 million HR professionals, I can share with you that they still seek information on a regular basis.
Thank you, Alex, for that. And absolutely seek information, and they are our conduit. Tell me what HR said happens so often. So let's move to the second part of our discussion today. And I wanted to give our audience some time to put some questions in the chat. And with 6 panelists, we're going to do things in kind of a lightning round fashion. So I'm going to ask some questions, some of which will go to everybody, but most of which will go to a few people. But I'm going to start with, I don't know if it's a softball or not, but a question for everybody real quickly. What one thing would you do differently in your area of expertise that, with the knowledge that you know now? The good or bad news about COVID is we learned so many things along the way. So I'm gonna throw that over to Nancy first, and then go real quickly. What's the one thing you would do differently with the knowledge you have now that you didn't have before? Nancy?
Okay, wow. So one certain thing that if we knew what we knew now back then, I think from a diagnostic testing perspective, we would have put lots more effort into variant analysis, which we didn't think was a problem before, and now we know is a problem. So purely from a diagnostic, variant analysis would be something we would have focused more on.
Completely agree there. Let's stick with diagnostic analysis of tests. Bill, to you.
Yeah, sure. I think that going off of Dr. Friedman's comment around plasticity, I'd actually focus on having more redundancy in our system from a diagnostic perspective, particularly as it pertains to infectious diseases, that they can have this massive scaling of demand, whether it's in the lab or, as we winnow down to be cost effective, you tend to limit. And there's some areas that actually should carry some surplus of capacity, and certainly infectious disease is one.
I appreciate that. And I think the whole definition of surplus in diagnostics, we've got to talk about instruments, disposables, and people. It's not just one of those 3. Steve, over to you. What do you think? What would you have done differently?
Centralize the dissemination of information out of politicians' hands. I mean, that just screwed things, and so to speak, and continues to be an issue where people think this is a political thing, choosing vaccine or not. And this is just a tragedy.
Gosh, so well said. Alex?
I would actually focus more on designing the infrastructure to expand to other providers. I think Nancy referenced this in her earlier comment. And for me, what still is jarring, and I've been on calls with CEOs of Henry Schein and other groups that offer our medical equipment providers. And one of the things they highlight is they still can't get the level of infrastructure that they need for physicians in their private practices to administer vaccine and to think about what it is that they can do to educate and administer tests. I think that would be the first thing I would go back to.
Great, Manny, and then Malia, I'm going to give you the last word because there were so many policy issues. Over to you, Manny. What would you do differently?
Hey, thanks, Mar. Absolutely. Again, the encouraging part is we really showed that through common focus and collaboration, rolling up our sleeves, we could leap tall buildings in a single bound in terms of the logistics and the technical aspects of implementing a diagnostic testing protocol. To me, I would say the refinement is collaborate across these different sectors on an even higher level, on a comparable, all-in type approach to focus on messaging, communicating, clarifying with the community, and really building trust and unified clarity and credibility among the work that we're doing.
Trust and credibility, so important. So speaking of which, Malia, over to you. What's so many things? What would be the one thing that you would do differently?
Yeah, and I think a lot of folks have mentioned this, but just to pick up on the thread, I think we sort of collectively were too slow to recognize the vacuum that existed and the opportunity to kind of take action that it presented. And I think really practically what I would do differently is that I learned the value of real world examples in that situation. Just there was such a big vacuum and there was so much confusion. And just I would have done that earlier, just said, hey, here's a thing that works. And like, let's talk about how it worked. Because that was some of the biggest change agents that I observed throughout the pandemic. And I would have done that sooner and sort of recognized that vacuum and that opportunity sooner.
Super, thank you. Clearly they should have come to this group of people, but anyway. So speaking of real world evidence and what happens in real world, we got a question from Catherine Sink. Does anyone see a medical need for antibody serology testing to check for protective antibodies after vaccination or infection? This has been something that with serology testing, there's really changed throughout the pandemic. Big thoughts that everyone was going to be tested, then no one, then back to a few people. And we're kind of now back to the CDC warning not to use that. So I'm going to go to Nancy, Bill, and Steve on this one. Nancy, you want to start?
Yeah, so I've had some conversations. I work very closely with the FDA these days, and we actually had a meeting just a week ago with the Imperial College of London and the FDA talking about serology testing to look for vaccine, the point where vaccine wears off. And I think the FDA is ultimately very interested in being able to use this, but we just don't have the data. There's the tests out there are really variable. The sensitivity and specificity is really variable. We just don't know what is the level that is good and what is the level that is bad. And I think there's been a tremendous amount of confusion. I think one of our core challenges with this entire pandemic is society has always looked at the scientists as having the answers. And here we don't have the answers because we don't have the data. And as the data comes in, the story and the recommendations change. So this is a perfect example of serology right now isn't ready, but we hope we get the data so that it could be used in the future.
That's interesting. I hadn't heard that perspective in terms of now versus a potential change. Steve, how are you seeing this and what do you think will happen?
I guess there's two sides to look at here. Number one is, the people who, for example, are on potent immunosuppressing drugs, do they have neutralizing antibodies? Have they made them? And I think we just don't know the answer. I know some physicians who have had organ transplants themselves are not going back to in-person visits if they don't have neutralizing antibodies. So with that data, you'd say, well, okay, let's check neutralizing antibodies in everyone. But then look at the Nature paper that just came out this week from Dan Baruch at our place here at Beth Israel Deaconess. He looked at the variants in people inoculated with the J&J vaccine, and he found that in a number of these subjects who got the vaccine, they did not have neutralizing antibodies, that variant, yet they had preserved T-cell responses against those variants, meaning that they were protective. So maybe kind of back to what Nancy's saying, we don't know what these serologies truly are meaning here. And it may be that, I think we have to understand more about just, your whole immune response is not just antibodies and what you get on a serology test.
Thank you. And Bill, anything to add to this one?
Well, I would just add that going back to both points, it's so unfortunate 15 months into this that we still don't have good enough data to draw conclusions on what serology can and can't tell us. I think the cause is multifactorial. It does include even some just differences. I mean, the pandemic exposed the difference of positions in the scientific and medical community. And I think even amongst infectious disease specialists, there's differences of opinions on serology. So, but it's just really unfortunate that we're at this stage and we still can't answer those questions one way or the other.
And so I appreciate that. And I think to Steve's comment, to me, I've been a student of personalized medicine for a long time. It has to be somewhat more personalized. The American public is not all of the same risk and all of the same approach. So that to me is one of the key things that I'm hearing for all three of you. Let me shift now to Steve Schuster's question about unvaccinated. In order to keep the workplace safe, how would you recommend companies handle their unvaccinated workers when they return to the office? So Alex, I'm going to start with you, go to Manny and Malia to talk about both practical issues of dealing with the unvaccinated and are there policy issues that we have to think about in that context?
So
Alex, you want to start?
Sure, I'll start with practical components, but also reference some of the policy issues. Specifically, what it has boiled down to is really a caste system, or in essence, a practical system that looks at two different classes of employees. And in practice, what we're seeing is that employers are creating opportunities for those who are vaccinated that aren't available for those who are not vaccinated. And unfortunately, it will impact the workplace to some degree by limiting promotability, as well as limiting what it is that certain workers can do. Our data alone says that 74% of employers are even making decisions about whether or not to hire someone based upon their vaccination status. And what that speaks to from a policy perspective is a vacuum that exists in terms of policy around that. And employers are left to do what they think they should do in that case. It's not well covered or even considered in most of our legislation or regulation today. And we're seeing that employers are applying that in their own practice as we speak.
Super, thank you. In the same question, but how do you deal with it in the schools, Manny? And kids are one thing, but maybe you could talk about it about teachers, how you deal with the unvaccinated teachers in close quarters.
Well, and I resonate with Alex's comments is that, you know, we've tried to just be as supportive and control and supportive of the variables that we can mitigate through access to vaccinations, education. We've had about 80% of our employees that we believe have been vaccinated. And so to provide that opportunity without mandating it, I think is supportive, and it empowers people to make individualized decisions for themselves, providing them those tools that they need to do their jobs, but also maintaining the fact that the expectations of professional norms are still in effect. So it's kind of that balance of both encouragement, education, but also accepting responsibility for that and still providing the tools for people to be able to do their jobs.
Super, really appreciate that. And at 80%, that's higher than many nursing homes or even hospitals. So very impressive. So Malia, over to you. How do you deal with the unvaccinated? Do you think that vaccination task force will ever get any traction? Will things change as we get closer to 70%?
Yeah, I think of it in sort of multiple stages, and sort of from the longest term view, I think what employers need and what they need from each other as examples, as well as from policymakers, is an understanding of what their options are when it comes to requiring vaccinations, and if and how that changes when the vaccines are no longer under EUA, but have full approval. And as we get more data, does that change? And sort of what's permissible by the law and by state and federal law. And there's just so much question there. And we're in another stage of this pandemic response where we are relying on individual businesses and employers to make these types of decisions for themselves and their employees. And that's really, really hard. And so I think ultimately that's the type of certainty that employers need. In the short term, I think that incentives and other sort of creative behavioral economics means to try to encourage employees to get vaccinated is where we need to go. And there's a number of studies that I'm aware of that are kind of exploring different ways to do that by connecting hesitant employees with practitioners that can kind of speak directly to their concerns, whether it's a matter of incentivizing vaccines with prizes and lotteries or days off or things like that, whether it's a matter of defaulting people into a scheduled appointment. There's a lot of kind of different ways that employers can incentivize and encourage. And then I think really immediately, kind of back to diagnostic testing, I think that there's a lot, we can require testing if you're not vaccinated, which gets to an incentive in some ways. You might not want to show up every week for a test. It's another reason to get vaccinated. But it's also a way to protect the rest of your employees and their families. And with all vaccines, there are certain people that will not be able to get vaccinated for their own personal health reasons. And it's those people that rely on the rest of us who are able to do so to get vaccinated. And so testing is one non-invasive way that we can kind of protect those workplaces and those employees.
Thank you, Malia. And I'm glad you connected vaccination with testing, because that is one of the incentives. And as we've talked about with the school program, in my mind, it's all about three things: mitigation, keep washing your hands and wearing masks in crowded places, vaccination, and also confirmation. Because as good as these vaccines are, and they are really good, we've never had a vaccine of this type. Well, we haven't had a vaccine of this type, but much better than the flu vaccine when we get to 94, 95% efficacy. And that confirmation comes with the testing. But let me, one thing, if people didn't notice, about 2 weeks ago, and I can send you a newsletter about this, the EEOC created guidance saying, one, you can, as an employer, offer incentives as long as they're not discriminatory. And secondly, EEOC issued guidance that they can require, an employer can require vaccination for people that are required to be in person. Alex, you went off mute, so maybe you have an additional comment there.
Oh, yeah, I say what I was going to reference is that is absolutely true. However, the way that employers are applying it is different, right? Much of what the EEOC has provided is non-guidance, in that you can require the information, you can ask for the information, but how you apply it, from either a selection decision, a decision to promote an individual, or to even allow them to come back in the workplace, has not been provided with any kind of guidance or any standard against that. And that's where organizations may not get themselves in trouble today, but down the line may do so.
I appreciate that, Alex, and giving an additional nuance to those pieces and emphasizing education. So we probably only have time for one more question. And Eric LaChance asked a question, but before I go to that, I'm just going to emphasize one thing. Leah Perkinson from the Rockefeller Foundation is on our Zoom, and she was able to update in the link to everybody participating that the Rockefeller Foundation issued the RAND report actually this morning, and it talks about school hesitancy amongst parents and their preferences for COVID-19 safety practices in schools. So you should see that in the link, and if not, go to the Rockefeller Foundation website and read more about what parents are thinking about their school. Critical, not as much for the summer session, but certainly as to where we'll be in the fall. So last question, as we think about the fall, what do we worry about? Nancy talked about it, which are variants. The importance of these variants. Occasionally we get lucky, and B117, which is now, I believe, the Alpha variant of concern, is one that was more contagious, more transmissible, but not more deadly, and pushed some of the others out. So the question going forward, and I'll leave this open for whoever wants to comment about it, is how do we deal with these variants? If we were testing for it and get the information, do we discriminate on whether somebody has one variant or another? How much sequencing or PCR testing should we be doing for variants? And do you think that this is a key issue to be concerned about moving forward? Nancy, you started this discussion, so I'm going to send it over to you first.
You know, this is another area that, golly, what we'll know in 6 months from now would be really helpful to know right now. So, you know, I think the CDC learned a lesson that they were under-resourced initially to analyze the variants, and now everybody's taking it very seriously. We are looking at all of the diagnostic tools out there to make sure that the tests, particularly the point of care tests, actually pick up the variants, because that would be really challenging if a lot of the tests come back negative, and indeed there are just because we're not picking up the variants. So I think the fall is going to be very interesting. I know society is ready to throw up their hands and say it's all done. Let's get on with our lives. Masks are off. Let's have fun. But I think testing in the fall is going to be really, really critical, even just to know what variants are out there so that we can stay ahead of this.
Yeah, as a lot of people have said, we may be done with COVID, but it may not be done with us. Steve?
You know, I guess a cautionary tale that I wish people around the world would understand is this is what viruses do. They mutate all the time. They come up with their own variants, and that's how they survive. And so, you know, people looking at this like, oh my, why wasn't I warned? How could this ever be? This is it. And we should, you know, I think there just needs to be more education of the public that this is what we should expect. This is why we can't let our guard down fully. This is why we're likely to need boosters. You know, I mean, this is why every year there's a different flu vaccine, is because, you know, we deal with these variants or mutations that occur. And so I think we just have to get people to understand this is the norm.
Well said, and I think that's a perfect area to end, that we're going forward. We have to acknowledge what the virus is and what we have to do to focus on it. So the future, whether we have boosters or not, what I heard from all of you is it's all about continuing education. Education on all levels, in the scientific community, the clinical community, the education community, as well as in the workforce. Government may be one place to coordinate that, but it's certainly not the only place. So with that, I'd like to send it back over to Nate to conclude for today, and thank you all.
Thank you, everyone, and that's all we have time for today. Thank you for attending, and we hope you enjoyed this conversation and took away some new ideas. The webinar recording will be sent in a post-event email and will be placed under the webinar tab of our COVID Commons website. In the post-event email, you will also receive a survey asking for your input about today's webinar, and we thank you for your participation. Finally, we encourage you to visit asucovidcommons.com to get involved. Once again, thank you for joining us today. Take care and stay safe.
Thanks, everyone.
All right, thank you.
Bye-bye.